Good afternoon, everyone. Welcome to the Nursing and Midwifery Grand Rounds for the month of May. The month of May is very important for nurses and midwives, and we all know the theme for this year for midwifery. It's sustainable midwifery, caring for tomorrow. And for nurses, it is our future. And so before we start the Grand Rounds, I just want to acknowledge the Aboriginal people and Torres Strait Islanders as this country's First Nations people. We recognize First Nations people and communities as traditional and cultural custodians of the lands on which we work to provide safe and quality health services. We pay our respect to their elders past, present, and emerging. And at the same time, we also acknowledge the CHHHS values of compassion, accountability, respect, and integrity. And take this opportunity to remind all of us as we are present here to keep our values up front. So once again, welcome everyone, those who are present in person as well as in online. We have got quite a number of audience through the online. Welcome to all of you. My name is Jaya Thomas. I'm the Nursing Director for Education and Research. So today, our presenter is Paul. And most of you know Paul. He's not unfamiliar to us. Paul has been a CNC, working as a CNC at CHHHS, and also as a consultation liaison psychiatry service for a very long time. Paul has been providing significant contributions in establishing new positions and programs that address clinical, social, and service development needs at various points along the health continuum. Paul has developed a diverse skill set across a number of clinical and educative roles in both general and mental health nursing. Paul holds hospital-based and postgraduate qualifications credentialed by the Australian College of Mental Health Nurses and has been a fellow since 2007. So Paul's very active on social media, and I'm sure if you Google Paul you will get better understanding of who Paul is. And I just want to thank Paul for coming here and being very keen to present for us, especially as I was mentioning, the month of May for nurses and midwives. It's very important that we hold ourselves in that professional perspective. So today's theme is the empathy trap, and Paul will be presenting on the session. So I would like to, on behalf of everyone, welcome Paul to the stage and hand over Paul to present.
Use this microphone or that one?
Yeah.
All right. And we're just waiting for the computer to catch up. It'll be with us any moment now. Now, see that there? It's not over there, which bothers me a little bit. Just talk amongst yourselves. This is me being distracting now. With today's session, I'm going to be touching on a couple of sensitive topics, including suicide. So just to forewarn you for that. And also, if you didn't notice it on the way in, there's some merch on the way out. And I'd be really grateful if you're working on a ward that you take as much of that merch as you feel that you need. And for you guys who are students from both JCU and CQU, if you would want to take some back to uni with you, you'd be very, very welcome. It's not doing much good there on the table. The other thing that I did, just stalling for time here, I'm about to sing a song, is airdropped a couple of contact cards on to Sarah, the CQU student's phone. So if you need to get some address cards about some of the stuff we're talking about, she's the person to contact. I might as well get started just while we're sorting this out. We thought we had it sorted before we started. I think nurses have a pretty good reputation around compassion, but quite often we reserve that compassion for the people that we're looking after. And so for the patients and their families, they probably get their fair share of compassion, but there's some pretty good evidence that we're not all that good at keeping it for ourselves and for each other. And and so what I want to do is turn the focus back onto us. AHPRA released some data earlier in the year which showed that 54 out of every 100 AHPRA registered health practitioners are nurses. The other bit of the data was that they said about 4 out of every 100 are midwives. I think they double dipped on the midwives because 3 out of every 4 midwives are also nurses, registered as nurses. So I think in total we make up 55% of the health workforce registered by AHPRA. Social workers don't get registered, but everybody else pretty much does who does clinical work. As we know, and you don't have to go looking at the data to work this out, you only have to look around the room. The vast majority of our profession is a female profession. About 89% of nurses are female, and about 99% of midwives are female. So I think particularly at a time like if you've been paying any attention to the media over the last few weeks, it's been kind of really bad news about the safety of women and the respect of women. And I think we should really celebrate that we work in a profession where nurses are forefront. And I'm really grateful that most of my mentors and peers have been women, and I just want to acknowledge the support that I've had from them. I'm just working through my presentation slide by slide here. Oh, here we are. Look at that. It's working. My God. And if we could just give Trina a little bit of a hand for helping us out. Thanks, Maddie. So that was surprising. That caught us all by surprise, didn't it? And look at that. There we go. That's working. So here are the first 2 slides. 55%, maybe midwives. And just seeing, I don't need this microphone. That's good. And mostly female. The next bit we want to take this with a bit of a pinch of salt. This is the Roy Morgan do a survey every year or two about the honesty and ethics of nurses. And they didn't really think about including us until the mid-90s. They started off with doctors and dentists. There's the health system for you guys. And then as a bit of a brain fart in the late 80s, they went like, oh, yeah, what about pharmacists? And then in the mid-90s, they said, oh, yeah, nurses too. Since they've included us in this survey, nurses have always ranked highest for amongst Australians for perceived honesty and ethics. But we should take that with a little bit of a pinch of salt, and I'll tell you why. See how we all dip down here at the end? What are these people thinking? So during the pandemic, we lost 6% in our honesty and ethics, and that's just crazy. About 6% of the population don't get vaccines. So it's that crazy 6% who still had their say. But that's, I think, a bit of a shame, because that's when I think we were at our finest. For those who weren't working here at the time, just a little bit of a recap. So this is data from this hospital from 2 years ago, a bit over 2 years ago. So remember how the Queensland borders were kept closed, and then we were really pleasantly surprised when they came up with a vaccine. And so we were pretty well shielded from it. While we were reading in the papers about hundreds, turned into thousands of health workers in the US and Europe and other places catching COVID at work and dying, we were up here in this little sheltered bubble, a long way away from all of that, and really grateful, because in those early days there was no vaccine, PPE was pretty hard to get, and even the testing wasn't all that flash. So by the time they got around to opening the borders, which is December 2021, the middle of December 2021, everybody who wanted to get a vaccine could have had one. That's 6%, obviously. Who cares? And then they open up the borders, and you can see there that first couple of weeks after the borders opened, not much happened. Where that first spikes up, I'm not sure, does the mouse work on here? No. Oh, can you see that? Oh, where am I? I can't see it. No, look, it's too hard for me. But where that first little jagged bit comes up, that's that first week in January. And respiratory and renal ward at the time had turned into being entirely, oh, Deirdre's got a gadget. What do I do with that? Shine it in their eyes. Don't be mean, Deirdre. Take this. There. Oh yeah, there he is. Isn't that fun? So just there, that was the beginning of January. Respiratory and renal had cleared out every other patient. It was a COVID-only ward. And it's a bit weird, if you've ever had that experience of switching from an Android phone to an iPhone or vice versa, where all of a sudden you think, I can work a mobile phone, it's not that hard. And then all of a sudden you're using a completely different operating system and you feel stupid because nothing falls to hand, everything is slow and clumsy. And it was a lot like that for me anyway, being in this new environment where we were in PP, in and out of PP all day long. And it was a difficult first week or two while we found our feet. But the nursing team, particularly on respiratory and renal, excuse me, did find their feet. And they needed to, because the customers kept on running in. The patients were building up and up. So within, I think, about 2 weeks, respiratory and renal was overflowing into the other ward on the 3rd floor, into Opera. They'd cleared out the older persons and repurposed that as a COVID ward. And then a week after that, we had to open up Surge North as a COVID-only ward. So we had 3 wards. It was scary. Come Australia Day, if you weren't anxious, you weren't paying attention. So the 26th of January, it's like, we're going to drown. With this wave of patients that were coming in, there was a few empty beds on Surge North, but respiratory and renal and the other ward on the 3rd floor were chockers. And everybody on the nursing teams anyway, they were looking at each other and be like, what happens next? What ward do we go to next? And we were very fortunate in that wave, that Omicron wave, crested at that point and fell away nearly as fast as it arrived, which was a great relief. This is an excellent picture of a Cairns hospital nurse surfing the Omicron wave. And she, probably a she, we've looked at the data, could have been a he, but most of the people working on those wards were women, mostly young women, nearly all under 40, nearly all under 30, to be honest. So these young women who were doing all this brave stuff, turning up to work, being really empathetic, putting the needs of others before their own, I felt, were doing such a good job, just amazing. And I guess the concern we had is if they were showing all that empathy towards others, were they really looking after themselves? And this is what we're worried about. And this is the purpose of me getting you here today, we should think about looking after ourselves. This is the worst bit of data you're probably going to see this week. This is data about suicide of health professionals. So we'll just try this little zapper here. So boys are blue, girls are green in this graph. And so this is people in other jobs, so males in other jobs. Male doctors kill themselves at about the same rate as males in other jobs. Male nurses, and there's a few of us here, fellas, we go at about 140% of males in other jobs. That's the same rate as people who leave the military under their own steam. People who leave the military because they're discharged against their will, usually a medical discharge, they suicide about 3 times the rate of us, but we suicide the same rate as soldiers who decide to leave the army. So it's high. Men always have a higher suicide rate than women. We do more lethal dumb stuff, which can't be reversed. Women self-harm more, but aren't quite as lethal and as dumb as we are. For the females, it's actually even more confronting. So as a ratio, female doctors and female nurses and midwives kill themselves at about twice the rate of females in other professions. Just looking at you, JCU and CQU students here, would have been nice if they told you that on day one. But it's alarming, isn't it, that we are in this really high-risk occupation from ourselves. And often there's a lot of emphasis put on when you're out on the wards about the suicide risk of our patients. Go to the tea room and look at your colleagues. We're the ones at risk. And I'm kind of making light of it, but it's true. The data doesn't really go into the reasons for that. Suicide's probably a bit too complex to unpack it all with confidence, but it's not always about psychiatric illness. Quite often it'll be about grief and loss. Quite often it's got a fair bit to do with intoxication. Quite often I think it's because people put the needs of others before their own needs and just run out of petrol. So this is where Jaya mentioned the values of CHHHS, one of them being compassion. We should take some of that for ourselves and think about self-compassion. Self-compassion is defined as being empathetic and understanding towards oneself as you might to a close friend in a times of need. And so that sounds like a doable kind of idea. I used to talk a lot about self-care when I was doing these sort of sessions with new grads and whoever else would listen. But I kind of felt like I was giving busy people another job to do. Self-compassion is more about an attitude. I am going to take this time for myself. If you've ever had a busy shift where you're running around putting catheters into people and then on the way home you think, I haven't had a wee today. That's what the empathy trap looks like, and that's where we need to put ourselves forward a bit. I've got some ideas, just three. So first one, gather around kids. Uncle Paul's going to tell a story. About 120 years ago in Wales, one of the miners there, his name was Dave, I'm making that bit up, he said, you know what, it's great having a job in a coal mine, it's really cool, but I go off and work all day, I get covered head to toe in coal dust and grease from the machinery and all that sort of stuff, and at the end of my shift, I spend an hour or so getting back home, having a shower and bath and whatever, washing my overalls, getting ready for the next day. If I'm getting messy on the boss's time, shouldn't I get cleaned up on the boss's time? And the other miners were like, Dave, you're a genius. Yes, that's right. Let's go tell the boss. And the boss went like, no, Dave, you're not a genius. You're an idiot. We can't afford to do that. We'll go broke. And so they went on strike, and they stayed on strike for months and months and months. Some of those Welsh mines were closed down for more than a year, until finally the mining boss had said, all right, Dave and friends, we shall let you get cleaned up at the end of your shift. We'll put in some above the mining pit. We'll put a pit head bath, so at the head of the pit, we'll put in some baths there, and you can get cleaned up using our hot water and our soap and just leave your dirty overalls there, and then you can go home. And if you remember from a few years ago with the Beaconsfield miners, where Todd and Brant were a fortnight trapped underground, and then we heard that they were safe and they were on their way out. They took a long time to actually get to the surface because built into the infrastructure of the mine was this pit head bath. So they got to stop to shower and shave and shampoo and what have you and get a change of clothes, and then they came and clocked off. And then they got hassled a bit by Koshi. But anyway, it's a really good thing to know. So we don't get all that much in the way of coal dust and grease on us at work usually. But we do, along with the skills-based labour that we do and the knowledge-based labour that we do, we also do that emotional-based labour. We sit there with other people's strong emotions, and that is going to affect us. Don't pretend it's not. Of course it will. So why don't we borrow this idea from the big buffy miners, and if we're going to get messy on the boss's time, why don't we get cleaned up on the boss's time? But how, I almost hear you ask? Well, somebody's thought about this before, and they've thought about this and have wound up calling it clinical supervision. It's not to get hung up on that name because it sounds like scrutiny or management, but it's not. If you're going to start again, you might call it something along the lines of guided reflective practice. But anyway, it's a thing where you get to take an hour or so out of your busy workplace, sit down with a trusted colleague or colleagues and reflect on what you're doing, talk about what you're doing in a safe space. Don't do it with your boss. Even if your boss is a really nice person, you don't want your boss to know when you're feeling overwhelmed or stupid necessarily. I don't want my boss to know what a dick I am. For God's sake, don't tell her. So clinical supervision isn't new for those of us who are specialised in mental health nursing. We've had it for a long time. And that's the guidelines going back there to 2009. We're actually excluded from a version in the early 2000s because they thought there was too many of us, and we were like, hang on, who do you think's doing all the work? In 19, before the pandemic, the Australian College of Nurses, Australian College of Midwives and Australian College of Mental Health Nurses put out this joint position statement saying, hey, it's really good that the mental health nurses are getting clinical supervision, but shouldn't all nurses and all midwives get it? And then in 2021, the Office of the Chief Nurse for Queensland Health said, yeah, you're right, we should all get it, and put out a framework that pretty much is an amalgamation of those other two documents, which says every nurse and every midwife, including students, should have access to some protected time with trusted colleagues to reflect on their practice. What are the functions of clinical supervision? They're probably best described, I think, by Bridget Proctor. She was really good at ending words with ATIVE, and she was also really good at describing the three key functions. So the formative is where you acquire new skills and new information. That's where you develop your knowledge. The normative is about the stuff about keeping you within those guidelines and guardrails that shape our practice. So, code of conduct, and are you sure that you're following the right policies and procedures, that sort of thing. And the restorative part of clinical supervision, the bit that I value the most, the bit that the specialist mental health nurse values the most, is where you get to delve into some of that emotional aspects of the work that we do. I'm a bit mental. I'd be 100% mental without clinical supervision. I think a knee-jerk reaction is like, look at us, like those nurses and midwives, they make up over half the health workforce. We can't afford to take them all offline to reflect on clinical practice. But the truth is, from a safety perspective, we can't afford not to. Two reasons. One, we saw the suicide data. We are more vulnerable than many of the people that we're looking after. But two, it's not good for patient care if we burn out and have empathy failure. I'm not sure if you've all worked with somebody who's had that burnout and empathy failure, but the patient winds up getting pretty crappy care. And so we're not just having clinical supervision for our own feel-good value. We're doing that so we don't lose empathy for our patients in a really difficult job. So clinical supervision is really good. Couple of quick things to finish on. When you're next at QEPs, if you think, actually it'd be good to get some information about stress reactions and how that affects people, it'd be good to get some information that I could take home to my family. Just get onto QEPs and put in the magic words bloody stressful, and up pops this old PDF. It's been sitting on QEPs since the late 90s, and we went to take it off, I'll say 15 years ago, I'm making that up a bit, when the Employee Assistance Program got their own QEPs page. And I was like, we don't need it anymore. But the lady who was doing the webmastering stuff at the time, she said, you're getting about 300 hits a month anyway, why don't you just keep updating it? So every year or two we just update it and people find it. But an easy way to find it, bloody stressful, into QEPs. And then this is my key message from today, is that and this is probably going to be the easiest thing to do, is please pull out your phone, grab these QR codes, because they've got the address cards for both of these organisations, which are bespoke support organisations for nurses, midwives and our students. The one on the right there, Nurse and Midwife Support, that's been around for about 6 years. It's 24-hour, 7-day-a-week phone support. And just that's a little reminder telling me to stop talking. Thanks, Siri. Such a... yeah, so that's 24 hours, 7-day-a-week, been up and running for about 6 years. That's really good. I bumped into Beth Mole, who was the secretary for the QNMU at the time, not long after it was launched, and I was saying, "Oh, isn't that great?" And she's like, "Yeah, it's not bad." I was like, "I thought the union would be right behind it." Turns out they had a different idea going, because the nurse and midwife support line, the 24-hour thing, that's actually funded via AHPRA, so they take a bit of our fees and prop that up. It's still confidential, they don't report back to AHPRA or anything. But it wasn't really quite what the union wanted. And so the union went and both the QNMU and ANMF got federal funding from the federal government to roll out the Nurse and Midwife Health Program Australia. That's Monday to Friday, not 24 hours a week, but provides ongoing counselling sessions. It's nurses and midwives who are providing support to other nurses and midwives. So on that, I invite you to get your phone, grab those QR codes, save this info on your phone now. If you never need to use it, that's really good. But I don't want you being out there not having access to it if you or one of your colleagues do need it. That's everything I had planned to say. Thank you.
Thanks, Paul. I'm sure you will agree with me. That's a very thought-provoking presentation, especially when we look at ourselves as professionals and nurses and midwives, where we have gone through a lot of, challenges especially during the pandemic times, and we still shine, and our profession, both nursing and midwifery, still stands in front, and the lots of announcements you may have heard includes now nursing placements for students that's coming on, and say there will be recognition, and that's very important. So thank you, Paul. That's really a very insightful presentation. I would like to invite anyone from the audience here to feel free to ask any questions or provide any comments for the presentation. If you have any questions, feel free to ask. And that invite is also for our students as well. So please do not hesitate to ask any questions. Anyone? No? Yes.
Paul, I'm just interested because I know you've mentioned clinical supervision, and I know you have such innovative out-of-the-box type thinking. So I guess two-pronged question. We haven't yet implemented the clinical supervision framework. So, and there's obviously some barriers and obstacles in getting that implemented into the health service. So if you've got what are your suggestions going forward in trying to implement that? But is there anything else that I guess we can be doing, or what you think the organisation should be doing to really support the nurses' well-being?
So thanks, Truman. So two-part question. One about implementing clinical supervision. But really easy for those of us who are in control of our own diaries, that we can quarantine an hour away from the workplace to do that. But if you're working on a ward, you're really relying on the structure of your shifts. So do we add on and turn it into overtime clinical supervision, or do we just restructure the organisation so it's built in part of the infrastructure, as it was for the Beaconsfield miners? So it's built in that there's time and space to do that. To get time, we need to have a good overlap between the morning shift and the afternoon shift, which I think always turns into like a 10-hour night. It's more expensive for the organisation, but it'll save nurses spending all their money at Dan Murphy's on their way home. And and that having that overlap in the shift would just free up that time. Then you've got to find the space away from the clinical workplace to do it, which is going to be tricky again. I'm not really sure of the solution for that. The second part is, what can we as an organisation do to make our workplace safer? I think just be really front and centre about that suicide data. It doesn't happen so much now, but 20 years ago, I would occasionally catch people out, not always nurses, but sometimes clinicians at the bedside when somebody would come in after self-harm or a suicide attempt and be really incredibly disrespectful. Oh, they're back again, why don't they do it properly next time, which is not only pretty unkind towards the patient, but also giving you a message to everybody within earshot around you that asking for help is somehow the wrong thing to do or something, which is ridiculous, of course. And I think when we encounter self-harm and suicide at the bedside, we should actually give each other the message that isn't it good that they've come here to get a hand? Isn't it good that we can be helpful in this instance? Even if it's just as a matter of redressing the wounds and being kind, that'll do for today. We don't have to solve all the world's problems, and kind of model that behaviour for each other, make ourselves explicitly kind. Yeah. That doesn't sound too happy.
Well, we have opened up any questions for the online audience as well. If you have any questions, feel free to unmute your mic and you can certainly ask. Or if you would like to put anything in the chat, we are more than happy to have that questions. So we have got one question from our audience. Colette, I was previously advised clinical supervision was not available for nursing in the HHS. What resources are there to support this being introduced and facilitated in teams?
The framework, so it has changed. That framework's only been sitting on QEPs for, I think it's dated 2019. 2021. I didn't actually see it in 2021. I didn't see it until 2022. So it's sitting there and it gives, I guess, you and our managers a framework to work from. How it's going to actually be implemented in each workplace, I'd imagine there will be an individual solution for each workplace. I don't think we can make it one size fits all. But the first thing is to find that framework. It's sitting on QEPs and just make sure that you and your colleagues know that this is okay. The Office of the Chief Nurse recommends it. Let's find a way.
Thanks, Paul. We also have a working group statewide that's been established, and Kathy Boyle, who's lead for the working group, and Chis has put her hands up to participate in that working group. It will start in June. We have been sent some dates, so that will also be some steps for us as an organisation moving forward on what we can implement. So that's a small achievement, but we'll work through that. Wonderful. I don't see any questions from the online. Any last minute comments or anything you would like to share while Paul is here? We're all good? Yeah, wonderful. Thanks, Paul. It's a privilege to have you on the stage to present this very important topic for our staff, especially in the climate that we are. We all feel burnout, we all feel fatigued, and we need to also start thinking about what are the strategies, as Paul reiterated many things on the presentation. Please take time to reflect. The sessions will be, this is recorded. We are working with comms to make sure the session is easily available. So that is a work that's happening behind the scenes. So we'll make sure we keep you informed. Couple of things. We have got the International Midwives Day celebration that happened on Sunday. Activities are continuing. We have a barbecue tomorrow morning. We also have the nominations for our Nursing Midwifery Excellence Awards. So please do that. The final date is the Friday. So we encourage you to nominate your colleagues and anyone who you would believe has we all deserve recognition. I'm sure you all appreciate that. But if you please can nominate, and let's put on and recognize our peers and colleagues within our, say, we can have good numbers of nomination, and hopefully we can get that through. But we'll continue to work with for our nursing midwifery grand rounds. As you know, this is a very initial sort of refinement that we are going through, and we have received quite a lot of feedback from our nurses and midwives, and lots of interest to present at the grand rounds. So our next presentation will be on the 22nd of May, and we will send out flyers and information very soon. With that, we will wrap up this session. Thank you, everyone. Thanks for joining, and I hope you all have a good week ahead. Thank you.